Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
All right, team, let's gather around. Let's kind of tighten up the circle here.
Yeah, let's step just outside bed 12, so we're out of the main traffic.
Perfect. I know the unit is, well, it's absolutely buzzing right now.
Yeah.
Pharmacy is still mixing the drips for that admission in 14.
And I think the fellow is currently down there negotiating with the CT tech about creatinine levels.
Right, and contrast loads. But we're going to use this downtime productively. We are doing a focused deep dive into the Circulation Guideline 2026.
The big multidisciplinary acute PE guideline.
Exactly. And honestly, looking at our board today, the timing really couldn't be better for this.
No, it really couldn't. Pulmonary embolism is, it's one of those diagnoses that creates just a fascinating amount of chaos on the floor.
Oh, absolutely.
Yeah.
Because it's not just one disease.
Right. It's a massive, sprawling spectrum.
It ranges from, the completely incidental finding on a staging CT.
Where they're sitting up eating a turkey sandwich.
Yeah, asking what's on the lunch menu. All the way to, well, the right ventricle is filing a formal complaint, the septum is bowing, and we are literally about to code.
The chaotic spectrum.
So the goal today is to take all that chaos for you guys and replace it with structured decisions. We want to replace that 2 a.m. panic with a solid, evidence-based protocol.
And specifically, we are looking at this massive consensus document. AHA, ACC, CHEST, AC. Pretty much every major society got in a room for this one.
It is a staggering amount of acronyms. It sounds like someone fell asleep on a keyboard.
It really does. But, that's actually the most important point to start with. You have cardiologists, pulmonologists, ER docs, interventional radiologists, vascular surgeons.
Hospitalists.
Right, hospitalists, too, all agreeing on the playbook. And the mission of this deep dive is simple. We are abandoning vague terms.
Yes. If I hear the word submassive today, I am going to frown.
Submassive is officially dead.
Agreed. We are fully adopting the new categories A through E.
So here is how we're going to break this down for you. We aren't just reading a list. We are walking through the actual life cycle of a PE patient right here on the floor.
We'll start with the diagnostic lens. How do we actually find it without over-testing?
Then we'll move into the new risk stratification, the alphabet of PE.
Then treatment. From those walkie-talkie patients to the ones crashing in the ICU. And finally, the long-term follow-up.
Sounds like a solid plan. We'll start with that diagnostic lens, because before you can treat it, you have to find it.
And find it intelligently.
Intelligently, yes.
So let's unpack this. The classic maneuver, and I see this literally every July, is to just order the CT pulmonary angiogram because the patient breathes funny.
Or their heart rate went to 101 for 6 seconds.
Right, the old donut of truth reflex.
The CT scanner is not a vitamin. That rule heavily applies here. We have to be disciplined. The guideline is incredibly clear that you cannot practice radiology by vibes.
Radiology by vibes, I like that.
You have to start with a pretest probability.
Now, we usually talk about the Wells score or the Geneva score for that, but let's get really practical for a second.
Okay.
If you have a patient who is low or intermediate probability, they aren't in shock, they aren't hypoxic, maybe just a little pleuritic pain, you go straight to the scanner.
No, you absolutely do not. And this is a key efficiency point that hospitals miss every single day. For low or intermediate probability, the guideline heavily emphasizes using a D-dimer to exclude PE safely.
But, and here is the massive nuance, we were talking about the age-adjusted D-dimer.
I feel like people always forget the math on this.
They really do. They see the lab cutoff is fixed at 500, the patient comes back at 600, and everyone panics.
But the patient is 85 years old.
Exactly.
We know that D-dimer naturally drifts up as we age. It's a marker of inflammation, of fibrin turnover. That just increases as you get older.
So what does the guideline actually say?
It says if the patient is over 50, the cutoff is not 500. It is their age multiplied by 10 micrograms per liter.
Let's do the math for everyone listening. Take that 85-year-old.
Simple. 85 times 10 is 850.
So if their D-dimer comes back at 750 and the lab software flags it in bright red as high because of that generic 500 cutoff.
Clinically, that is a negative D-dimer. You have entirely ruled out a PE. You do not need the CT.
That saves the patient a hefty contrast load. It saves them radiation.
It saves the system $1,000.
And it saves you from finding some tiny, clinically insignificant subsegmental clot that might not even be the actual problem.
Which just leads to completely unnecessary anticoagulation and bleeding risk.
Right. Now, for the trainees who love a good rigid algorithm, the guideline also brings up the years algorithm.
Yes. Years has been gaining major traction in Europe for a while, but it is front and center in this guideline now.
It's fantastic for reducing unnecessary imaging. It basically boils the whole decision down to 3 specific criteria, 3 questions you have to ask yourself.
Question number 1. Does the patient have clinical signs of a DVT? So swollen leg, a tender calf, redness.
Okay, that's 1.
Question 2. Is there hemoptysis? Are they coughing up blood?
Which is pretty rare, but highly specific when you see it.
Exactly. And question 3. Is PE the most likely diagnosis?
This is where your clinical gestalt actually matters. Do you genuinely think it's a PE, or do you think it's a pneumonia, or maybe just a musculoskeletal strain?
Right. So you have these 3 binary questions.
How does that actually change the D-dimer math we just talked about?
This is the coolest part. If the answer is no to all 3, meaning 0 years items are present, the D-dimer threshold to rule out a PE jumps all the way to 1,000.
Wow. So if you have a patient with vague chest pain, no swollen leg, no blood, and you think it's probably just a pulled muscle, you can tolerate a D-dimer of 900 and still safely say no PE.
Correct. You rule it out completely.
And if they do have 1 or more items, say they do have a swollen calf.
Then the threshold drops back down to the standard 500. But utilizing that 1,000 cutoff for the 0-item group saves a massive amount of unnecessary scanning.
That is a huge operational difference.
Yeah.
Now, let's pivot to a specific population where diagnosis is always high stakes. Pregnancy.
Oh, this is always a tense diagnostic dilemma on the floor.
It really is. You have a young, healthy patient. You are terrified of radiation exposure to the fetus, but pregnancy itself is a known hypercoagulable state.
The stakes are incredibly high. The guideline does note that an adapted years algorithm in pregnancy can significantly reduce imaging.
But let's say you've done the D-dimer. You've done the bilateral compression ultrasounds of the legs, and they are totally negative, but you still highly suspect a PE. You have to image the chest.
Historically, I feel like everyone was pushed toward VQ scans for pregnant patients.
Yeah, ventilation perfusion scans. The thought was always to spare the maternal breast tissue from CT radiation.
The pendulum has officially swung on that. The new guideline actually states that if the chest X-ray is normal, a low-dose CT pulmonary angiogram is reasonable and often preferred over VQ.
Really? Why a major shift?
A few distinct reasons. First, modern CT scanners have low-dose protocols that significantly reduce the radiation burden compared to the older machines we used 15 years ago.
The technology got better.
Much better. Second, VQ scans are notoriously frequently indeterminate.
Which is the worst feeling.
It is. So you radiate the fetus with the isotope, you wait for the read, you get a result that essentially says maybe, and then you have to wheel them down to get the CT anyway.
Double the exposure.
Exactly. CT gives you a definitive binary answer, yes or no.
And it shows you alternative diagnoses. If it's not a PE, maybe it's an aortic dissection, maybe it's a weird pneumonia. VQ tells you absolutely nothing about those.
Nothing at all. So do not be afraid of the CT in pregnancy if the clinical suspicion is genuinely high. It is often the safest path to a rapid, definitive answer.
Okay, one more major point of confusion on the diagnostic side. I see this with interns all the time, and frankly, some older attendings too. They order a bedside echocardiogram to diagnose the PE.
Please, let's stomp that practice out right now.
They say, I'll just throw the probe on. If the heart looks good, there's no PE.
An echocardiogram is not for diagnosis. I cannot stress this enough. It is for risk stratification.
Say that again for the people in the back.
Echo is for risk, not diagnosis. An echo can tell you the right ventricle is angry. It can tell you the pressure in the lungs is up. It can tell you the RV is dilated.
But it cannot tell you why.
Exactly. A dilated RV could be a massive PE, sure. But it could also be pulmonary hypertension from 10 years of uncontrolled sleep apnea. It could be severe COPD. It could be an isolated RV infarct.
It doesn't actually see the clot.
It rarely sees the clot. Unless you catch a transit clot literally floating through the right atrium or ventricle on the screen, which is rare, do not substitute an echo for a definitive clot picture.
You use the echo after you know they have a PE to figure out exactly how scared you should be.
Precisely.
Perfect. So we have the diagnosing phase locked down.
Correct.
We used our pretest probability, we used our age-adjusted D-dimer or years, and if needed, we got the CT. We found the clot.
We have a confirmed pulmonary embolism.
Now we enter the absolute core of the guideline.
The framework, the top 10 take-home messages that really form the spine of this entire document. And they basically boil down to an entirely new language.
Let's start with message number 1. This is the big one. The classification system.
Goodbye, submassive. Hello, categories A through E.
I am genuinely so glad to see submassive go. It was always a nightmare to explain to families. You'd say, so it's massive, but sub.
It sounded like a sandwich order at a deli.
It really did. And massive was dangerously misleading because people naturally assumed it meant the physical size of the clot was huge.
But it actually just meant their blood pressure had tanked.
Exactly. It was so imprecise.
The new system is granular. It is specifically designed to triage the patient to the right physical bed in the hospital or to home. So let's break down A through E slowly because this is how we are all going to be talking for the next decade.
Let's do it. Category A.
Category A is subclinical or incidental. This is the patient who got a CT scan for their cancer staging or maybe a trauma pan scan after a car wreck.
And the radiologist calls an hour later and says, hey, there's an incidental PE in the right lower lobe.
Right. The patient is completely asymptomatic. They feel totally fine. Their vitals are perfect. That is category A.
Category B.
Category B is symptomatic, but they have a low clinical severity score.
So they have some chest pain, maybe a little shortness of breath.
Yes, but their heart rate is okay. Their oxygen is okay. They are hemodynamically rock solid. They just have the clot and some symptoms.
Now, category C.
This is where it gets spicy. Category C is symptomatic with an elevated severity score. This corresponds roughly to the old submassive group.
These patients are hemodynamically stable, right? Normal blood pressure.
Normal blood pressure, but the engine is straining underneath the hood.
What specifically defines that strain in the guideline?
Two things, right? Ventricular dysfunction on imaging, so either on the CT or that echo we talked about, or elevated biomarkers, meaning a positive troponin or BNP.
If you have either or both of those, you're category C.
RX.
Let's pause on the physiology here for a second because I think it helps to understand why we care so much. Why do we care if the troponin is 0.05? It's a tiny, tiny leak. They aren't having a massive STEMI.
It is the early warning sign for the spiral of death.
The RV spiral.
Think about the pure anatomy. You have a physical clot blocking the pulmonary artery. The vascular resistance skyrockets. The right ventricle is a thin-walled, wimpy chamber. It is designed entirely for low-pressure pumping.
And suddenly it has to push against a brick wall.
Exactly. So what does it do? It dilates. It stretches out.
And because the RV shares a physical wall with the left ventricle, the septum, that dilated RV, starts pushing the septum over into the LV space.
It creates septal bowing. It literally smashes the left ventricle. Now, the LV cannot fill with blood properly.
If the LV can't fill, it can't pump. Cardiac output starts to drop.
The blood pressure might be maintained for a while because the body clamps down on peripheral vessels to compensate, but the actual forward flow is dropping.
And crucially, the coronary arteries that feed that straining right ventricle rely on that aortic pressure.
Right. So the RV is working twice as hard but getting less blood flow. So the RV tissue gets ischemic. That is where your troponin leak comes from.
It is the RV crying for help.
It's microscopic cell death in the right heart.
So a category C patient is basically standing at the very top of a slippery slide. They look okay on the outside, but the RV is starting to starve.
Precisely. They are the watchers.
Which brings us to category D.
Category D is a totally new, distinct bucket in this guideline. Incipient cardiopulmonary failure.
The incipient failure. So this is the patient who is actually sliding down the slide.
Yes. They have transient hypotension. Maybe their pressure dipped to 85 systolic, but it came back up when you gave them a fluid bolus. Or they have normotensive shock.
Define normotensive shock for the trainees listening. That phrase sounds like an oxymoron.
It means the blood pressure number on the monitor is technically normal, say it reads 100/60, but the actual tissue perfusion is failing.
So how do they look?
They look terrible. They are clammy. They are sweaty. They may be slightly confused or agitated. Their lactate is rising. Their urine output is dropping off.
Their body is absolutely maxed out on compensation.
They are teetering right on the edge. They are about to crash hard.
And finally, the crash itself.
Yeah.
Category E.
Category E is cardiopulmonary failure. Persistent hypotension, meaning a systolic under 90 for more than 15 minutes, shock requiring vasopressors, or frank cardiac arrest.
This is the massive PE of the old nomenclature. The house is entirely on fire.
Yes.
There is also an R modifier you can use, right?
Yes, you can tag an R onto any of these categories if there is significant respiratory distress or severe hypoxemia. So you could have a patient who is category CR.
Okay, so we have our new buckets, A, B, C, D, and E. Now, the guideline tells us exactly what to do with them. This brings us to what is arguably the most culturally controversial part of the whole guideline.
Disposition, what do we put them?
Right. Message 2 and Message 3 cover those walkie-talkies.
Message 2 says, Category A, the asymptomatic incidental folks, can be safely discharged directly from the ED.
And Message 3 says Category B, the symptomatic but low-severity patients, are generally recommended for early discharge as well. Okay, I hear you. But let's be real for a second. Put yourself in the shoes of the ER attending at 2 a.m. I see a large clot on the CT scan. You are telling me to send that patient home.
Yes.
My internal alarm bells are screaming. I am immediately thinking about the plaintiff's attorney reviewing my chart in 6 months, saying, "Doctor, you literally saw a blood clot in the patient's lung, and you sent them to their house." How do we defend that clinically?
That is the massive emotional hurdle we have to get over, but the objective data is your defense. The guideline explicitly states that hospitalization for true low-risk patients, those category A's and B's, actually increases their harm.
Increases harm. How? They're in a hospital surrounded by doctors.
We expose them to hospital-acquired infections. We interrupt their sleep constantly. We stick them with needles for unnecessary morning labs. We prescribe broad-spectrum antibiotics because they spike a tiny fever that isn't even an infection. It's just inflammation from the clot.
We feed them terrible hospital food.
We immobilize them in a bed, which is exactly how they got the clot in the first place. The so-called safe choice of admitting them isn't actually safe. It's just expensive and highly prone to iatrogenic error.
But, and this is a very big but, we cannot just eyeball low risk. I can't just look at a guy and say, yeah, he looks pretty good to me, send him out.
Absolutely not. The guideline insists on using validated objective scores. We need to talk about the SPEZE and the HESTIA criteria.
Okay, let's pause on the math here. The SPEZE, the Simplified Pulmonary Embolism Severity Index. We always say just run the score, but remind us what actually flags a patient as high risk on that tool.
Oh.
What are the variables?
It is exactly 6 variables, and they are ruthlessly practical.
Go ahead.
1 point for age over 80, 1 point for a history of cancer, 1 point for chronic cardiopulmonary disease, so CHF, or severe COPD.
That's the history side.
Right. And then 3 vital sign parameters. Pulse over 110, systolic blood pressure strictly under 100, and oxygen saturations under 90%.
So if they have any of those, just a single point, they are not considered low risk by the score.
Right. An SPCE score of 1 or more means you probably shouldn't be discharging them immediately. A score of exactly 0 implies a remarkably low 30-day mortality risk.
Let me push back on that for a second. Say you have a 40-year-old guy. He has pleuritic chest pain. Because he is in severe pain, his heart rate is 112. Does he fail the SPECI?
Technically, yes. He gets 1 point for the tachycardia, and that is exactly where clinical judgment and the HESTIA criteria come in as a necessary counterbalance.
HESTIA is more of a safety checklist, right?
It's a clinical and social safety checklist. It asks 11 questions, but they are incredibly pragmatic.
Like what?
Things like, does the patient require oxygen therapy? Are they in severe pain requiring IV narcotics? Is there a high risk of active bleeding? Do they have acute renal failure?
And the social stuff.
Crucially, yes. Is there adequate social support? Can they physically get to the pharmacy to get the medication?
And that is the real world, can they actually function at home?
Yes, exactly. If the SPEZE is 0, and they pass all the HESTIA criteria, meaning they have their meds, they have a ride, they aren't bleeding, then the hospital is simply not the right place for them. Discharge them.
The conversation is basically, you have a PE, we are treating it with a highly effective pill. Go sleep in your own comfortable bed.
But you must ensure follow-up. You cannot discharge a PE into a void. They need a phone number to call if things worsen, and a concrete appointment in 1 to 2 weeks.
Okay, so categories A and B are the get them out of here groups. Now, let's move to the inpatient side of the board. Message 4. Categories C, D, and E should be hospitalized.
This makes intuitive sense. Category C implies the right heart is actively straining. They are the watcher group. They are stable right now, but they have drastically less reserve.
These are the patients I always admit to telemetry or a step-down unit. I don't want them on a general floor. I want to know instantly if their heart rate drips from 90 to 1 in 10. I want to know if they get dizzy just walking to the bathroom.
Exactly. You hospitalize them to optimize their treatment and, crucially, to monitor for deterioration. Because if they throw another piece of clot, or if that RV spiral tightens even slightly, they slide right into Category D.
And D and E are obviously mandatory ICU level care.
Without a doubt. Category D, that incipient failure group, needs eyes on them constantly. They are teetering.
Let's talk about treating that teetering patient, because this is where the guideline gets heavily nuanced. Message number 5 is all about advanced therapies.
Catheter-directed lysis, systemic TPA, surgical embolectomy.
This is the reasonable versus considered debate, and the wording here was chosen very, very carefully by the committee.
It was. Let's break down the semantics because they dictate our actions. For category E1, that is the patient in frank shock advanced therapies, are considered reasonable.
Reasonable is a strong guideline word. It essentially means you should probably do it unless you have a remarkably good reason not to.
Yes. If a patient is in shock from a PE, giving them heparin alone is usually just not enough. The mortality is far too high. You need to mechanically or chemically remove the obstruction right now. Systemic thrombolysis is the standard there if their bleeding risk is acceptable, mostly because it is incredibly fast.
But for category D, the incipient failure, the normotensive shock folks, the guideline says advanced therapies may be considered.
That is a much softer word. Considered. It means you need to pause. You need to look deeply at the patient in front of you.
Why the hesitation? If the RV is struggling that much, why not just blast the clot and fix the plumbing?
Because bleeding kills people, too. Systemic lysis carries a known risk of intracranial hemorrhage, catastrophic brain bleeds of about 1 to 2%.
That is not a trivial number.
It's not. Catheter-directed therapies are certainly safer from a bleeding perspective, but they take time to set up and require specialized expertise. In category D, the patient isn't actively dying yet, so you have to constantly weigh the risk of the therapy against the risk of the disease.
It's a yellow light. Proceed with extreme caution.
Correct. You look at the trajectory. Is the lactate going from 2 to 4 to 6 over 3 hours? Then yes, you escalate. Is the lactate perfectly stable at 2.5 and the patient looks relatively comfortable breathing room air? Maybe you hold off, let the anticoagulation work, and keep them under a microscope.
And who exactly helps us make that highly complex judgment? That brings us to message number 6, which is near and dear to my heart. The Pulmonary Embolism Response Team. The guideline strongly recommends PERT implementation, specifically for categories C through E.
I genuinely love PERT because it definitively stops the solo hero mentality in the ICU. It stalks cowboy medicine.
It creates an immediate consensus. You get interventional radiology, interventional cardiology, cardiac surgery, critical care, and hematology all on the same phone call.
It's a hive mind.
Exactly. Imagine you are the intensivist on nights. You see the severe RV strain, you see the vitals softening, you want to push TPA. But maybe you missed buried deep in the chart that the patient had a spinal surgery 10 days ago.
The PERT catches that. The hematologist chimes in and says, whoa, hold on, that is an absolute contraindication to systemic lysis.
And then the interventionalist steps up and says, I can take him to the lab and suck that clot out with a large bore catheter without using any systemic TPA.
That is the immense value of the team. It navigates the gray areas. Because, honestly, the clinical trial data for Category D is just not perfect. We do not have a massive randomized controlled trial for every single permutation of patient comorbidities.
So when the data is gray, you rely on the combined decades of experience of 5 different specialists to find the safest path.
The guideline notes that P8 explicitly improves the timeliness of care and the safety of decision-making.
We're moving on to the actual drugs. Message number 7, parenteral anticoagulation.
If you need to use an injectable blood thinner, so usually in the hospital for those category C, D, and E patients, The guideline recommends LMWH, low molecular weight heparin, over unfractionated heparin.
Now, this is an absolute dagger to the heart of old-school intensivists. We love our heparin drips. We feel so safe with the drip because we think, oh, if they bleed, I could just turn it off.
It is a total false sense of security. Think about the pharmacology of unfractionated heparin. It binds to plasma proteins, it binds to macrophages, it binds to endothelial cells, and it does so completely unpredictably.
Which is exactly why we have to check the PTT every 6 hours.
And you end up just chasing levels all day and night. You're subtherapeutic, so you give a huge bolus. Then 6 hours later, you're wildly supertherapeutic, so you stop the drip. It is a complete roller coaster.
And in the middle of an acute PE, you need therapeutic levels right now. You cannot afford 12 hours of subtherapeutic time while you fiddle with the drip rate protocol.
Exactly. Low molecular weight heparin-like Levinox gives you instant, highly reliable bioavailability. You give the sub-Q shot, and you know, objectively, they are anticoagulated.
Plus, it has a drastically lower risk of heparin-induced thrombocytopenia, or HIT.
So when do we actually still use the UFH drip?
There are really only 2 scenarios where the drip is still king. One is severe renal failure, a creatinine clearance under 30, although even there, some newer data supports dose-adjusted LMWH.
And the second scenario?
An imminent procedure. If you legitimately think you might be rolling that patient to the OR or the cath lab in the next 2 hours for an embolectomy, use the UFH drip, because its half-life is incredibly short when you do turn it off.
Otherwise, just give the Levinox.
Message number 8, oral anticoagulation.
This one is very well established now, but it was heavily reaffirmed. DOACs, direct oral anticoagulants like apixaban, rivaroxaban, are highly recommended over vitamin K antagonists like warfarin.
Warfarin is cheap, but it's an absolute nightmare for the patient. Dietary restrictions, constant INR checks at the clinic, DOACs are basically fire and forget.
Unless they are contraindicated, of course, like in severe antiphospholipid syndrome or if they have mechanical heart valves.
But there's a really interesting note in the guideline here regarding body habitus.
Yes. The guideline explicitly states this DOAC preference applies to obesity as well.
That is a big update. We used to deeply worry that if a patient was over 120 kilos or had a BMI over 40, the DOAC just wouldn't be absorbed well enough into the bloodstream.
The recent pharmacokinetic data has totally reassured us. Even with a BMI well over 30 or very high body weight, DOACs are entirely reasonable and effective. The standard doses work. You do not need to force a patient onto warfarin just because of their weight anymore.
That's a huge win for patient quality of life. Message number 9, duration of therapy.
Extended anticoagulation. The old 3 months and you're done rule is fading away.
It really used to be. You have a PE, take this pill for 90 days, then throw the bottle away.
Now we heavily divide PEs into provoked and unprovoked, or, more accurately, transient risk factors versus persistent risk factors.
So if you had a clear transient trigger, I broke my femur in a skiing accident and was immobilized in a cast for 6 weeks, then 3 months of therapy is perfectly fine. The trigger is completely gone.
But if it was unprovoked, I was just watching TV on a Tuesday and my lungs start hurting.
Then the underlying risk of recurrence is alarmingly high.
The guideline highly recommends extending therapy beyond 3 to 6 months for those folks, often indefinitely, or at least until a major bleeding risk eventually arises. As they age, we are treating a chronic tendency to clot, not just a one-time freak event.
And finally, message number 10. This is a massive one for the outpatient follow-up world.
Long-term screening. The guideline absolutely mandates that we actively ask about symptoms and functional limitations for at least 1 year to screen for CTEPD.
We pronounce that CTEPD, chronic thromboembolic pulmonary disease.
Yes. We often discharge these PE patients from the hospital and just say, good luck, see you later. But a significant number, up to 4 or 5%, do not naturally dissolve that clot completely.
It scars down inside the vessel,
It becomes this hard, fibrous material permanently lining the inside of the pulmonary arteries.
which slowly but surely leads to severe pulmonary hypertension and right heart failure years later.
Exactly. So if a patient comes back to the clinic at 6 months and says, I still get really winded just walking to the mailbox, do not blow that off.
Do not say, oh, you're just out of shape, you've been resting too much.
That is the trap. We blame the patient for deconditioning. You need to actively screen for CTEPD.
Usually a VQ scan is actually the screening test of choice here, right?
Yeah.
Because it's exquisitely sensitive for those chronic, mismatched perfusion defects.
Correct. And if they have it, there are incredible treatments available now, balloon pulmonary angioplasty, or even a full pulmonary thromboendarterectomy surgery. You can literally cure their heart failure, but only if you look for the disease.
Okay, that was an absolute marathon through the top 10 takeaways. Let's take a breath. Those messages are the clinical spine of the document. But theory is one thing. Actually standing out here outside bed 12 is another.
Let's operationalize it. Let's run a few scenarios.
We'll run 3 mini cases to see how this genuinely feels in practice. Scenario 1, the walkie-talkie.
Lay it on me.
You are down in the ER. A 45-year-old male comes in complaining of right-sided pleuritic chest pain. No other medical history at all. Vital signs are absolutely perfect. Heart rate 72, setting 98% on room air, BP 130 over 80. The CT scan shows a segmental PE in the right lower lobe. The right ventricle looks totally normal. The troponin is undetectable.
Okay. First, we establish the classification. He's symptomatic, but totally stable. No tachycardia, no RV strain, no positive biomarkers. This is classic category B.
The ER resident turns to you and asks, should we admit him for 24 hours just to watch him, just to be safe?
And you, holding the 2026 guidelines, say, absolutely not. You run the SPE's score right there, ages 45, so 0 points. No cancer, 0. No CHF, 0. Vitals are all normal, 0. His SPE's score is 0.
So he's objectively low risk.
Then you run the Hestia criteria. Is he actively bleeding? No. Does he have a home to go to? Yes. Can he physically and financially get the apixaban from the pharmacy? Yes. The decision is discharged.
That feels bold if you aren't used to it, but it is the right medicine.
You start the DOAC right there in the ER. Literally hand him the first pill. You verify his follow-up appointment, you educate him on the exact warning signs to look out for, and you send him home. Admitting him to the floor adds 0 value and only introduces risk.
Spot on. Scenario 2, the watcher. This is the exact patient that keeps me up at night.
Let's hear it.
58-year-old female. She is slightly tachycardic, heart rate is 115, blood pressure is totally fine, 125 over 80. But the CT shows a massive saddle PE sitting right at the bifurcation. The RV to LV ratio on the scan is 1.2, so the right ventricle is visibly enlarged, and her troponin comes back positive at 0.15.
Okay, let's classify her. She is symptomatic. She has an elevated severity score precisely because of the positive biomarkers and the visible RV dysfunction.
But she is normotensive.
Right. So this is a classic category C. Specifically, we'd call it C3 because she has both the abnormal RV and the abnormal biomarker.
Disposition.
Admit, 100%, this is not a discharge candidate. This is the hospitalized to optimized group.
Do we call PERT for her?
Yes. The guideline strongly states that PERT is recommended for category C through E. So I would absolutely activate PERT, or at the very least, pull together a multidisciplinary huddle.
Why, though? She's hemodynamically stable. Her pressure is 125.
She is stable right this second, but she has 0 physiological reserve left. She is teetering at the very top of the RV spiral. If that heart rate goes up just another 15 beats, or her pressure softens to 95, she instantly becomes category D.
PERT allows you to make a plan ahead of time.
Exactly. You ask the team, if she drops her pressure at 3 a.m., are we doing catheter-directed lysis? Are we doing systemic TPA?
Yeah.
You make the high-stress decision in the calm light of day before the crash actually happens.
And what's her initial treatment?
Start LMWH, a weight-based dose, like 1 milligram per kilogram twice a day. Do not put her on a heparin drip. The LMWH will stabilize that clot much faster and more reliably, and then you watch her like an absolute hawk. Continuous telemetry, frequent vital checks. You're looking for any sign of a slide into category D.
Which brings us perfectly to scenario 3, the crashing patient.
The nightmare.
65-year-old male. He looks gray and sweaty. He is conscious, but his blood pressure is clearly drifting downward. It was 110 an hour ago. Now it's 90 over 50. His lactate just resulted at 4.0. He physically looks like he is dying.
Okay, now we are crossing a major line. If he has this normotensive shock picture, with clear hypoperfusion, the sweating, the elevated lactate, or he's having transient drops, he is category D.
And if that pressure stays down below 90 for 15 minutes,
then he is fully category E.
Action plan.
Activate P8 immediately. Do not wait. This is the code PE moment.
And this is where the advanced therapy conversation becomes urgent.
Right. He is category D, actively tipping into E. The guideline says advanced therapies are to be considered for D, or are fully reasonable for E. You are not just observing anymore, you are actively preparing to escalate.
Let's say he drops to 80 over 40 and stays there despite fluids. He is now undeniably category E1.
E1 is cardiopulmonary failure with shock. Advanced therapies are highly reasonable here. If his bleeding risk is deemed acceptable, meaning no recent brain surgery, no active GI bleeding systemic thrombolysis is usually the fastest way to offload that dying right ventricle.
Because it works in minutes.
Yes. Taking him to the cath lab takes time to assemble the team and prep the groin. Push TPA works right now.
But what if he completely arrests? He codes right in front of us. Category E2.
E2 is refractory shock or cardiac arrest. This is the absolute extreme. The guideline specifically brings up VA ECMO here, veno-arterial extracorporeal membrane oxygenation.
The ultimate bridge to recovery.
Exactly. If your center has rapid ECMO capability, E2 is the exact time to deploy it. It completely bypasses the blocked lungs and offloads the failing heart instantly. It buys you hours to figure out how to physically remove the clot.
Interestingly, the guideline explicitly notes that surgical embolectomy cracking the chest is not recommended over other therapies in an active arrest scenario unless the patient is already on ECMO support.
Right. You just cannot efficiently do a full sternotomy and open the pulmonary artery during active chest compressions. It is a total bloodbath. You need the bridge, either systemic lysis or VA ECMO, to stabilize them enough for surgery or a catheter intervention.
That distinction is so vital for the team to understand. In E1, which is shock, you have multiple options: lysis, catheter extraction, or surgery. In E2, which is arrest, you need immediate systemic flow, lysis or ECMO.
Precisely. And in all of these rapidly deteriorating D&E cases, having that PERT structure in place helps you make that exact decision incredibly fast. You do not want to be standing at the bedside debating the weight-based dose of TPA while the patient is coding. You want a pre-built protocol.
Absolutely. Okay, let's pivot slightly to a specific management role that often gets completely overlooked, but it can cause massive long-term issues for the patient. IVC filters.
Oh, the IVC filter. The umbrella, the ultimate security blanket of the vascular world.
We used to put these in literally all the time 15 years ago, just in case. Oh, we clot, let's drop a filter in.
And the guideline has come down incredibly hard on that historical practice. It assigns a Class 3 recommendation to routine IVC filter placement in patients who are adequately anticoagulated.
Class 3 means harm. That is not ambiguous medical speak. That means stop doing it.
Stop doing it immediately. If a patient is successfully on a blood thinner, putting a metal cage in their vena cava does not help them. It actually significantly increases their risk of a new DVT at the insertion site.
And the filter itself can cause chaos.
It becomes a nidus for massive clots. The filter clogs up entirely, and the patient gets horrific permanent leg swelling. The filter can migrate. The metal struts can fracture and send sharp shards right into the heart or the lungs. It causes real, tangible complications.
So when do we actually use it? There must be a clinical exception.
There are really only two valid reasons. Number one, an absolute, undeniable contraindication to anticoagulation.
Like, they come in with a massive PE, but they also have an active subdural hemorrhage in their brain.
Exactly. You obviously cannot thin their blood, so you put in a filter to stop the next clot from hitting the lungs. Number two, recurrence despite fully therapeutic anticoagulation.
So they throw a brand new PE
Mm-hmm.
while they are strictly compliant on their DOAC, and we know their levels are perfect.
Right. That's a failure of medical therapy.
Yeah.
Then maybe you filter them.
But even then,
The guideline stresses you want a retrievable filter, and you want to retrieve it as soon as clinically possible. Do not leave it in there for 5 years. It is a temporary mechanical bridge, not a permanent implant.
okay, we are nearing the end of our rounds here. I can see pharmacy has almost finished the drips for room 14. Let's talk about the long tail of this disease one more time, the post-acute phase.
We touched on extended anticoagulation earlier, but I really want to emphasize the actual conversation you have at discharge.
It's not just handing them a prescription script and saying bye.
No, you have to frame their physical expectations. You need to look them in the eye and say, you might feel easily winded for a few weeks. That is a normal part of the healing process. But if you are still feeling winded in 3 months, that is not normal.
You have to empower the patient to actively report their symptoms.
Because if we miss the development of CTEPD, we essentially condemn them to progressive right heart failure.
And we also need to remember the sheer mental toll of a PE. Post-PE syndrome isn't purely physical. It's severe anxiety.
Will it happen again? Is that little twinge in my chest another clot trying to kill me?
Addressing that mental health aspect, validating that fear, is actually a recognized part of the guideline too.
It is. It's comprehensive care.
All right, we are officially rounding the corner to the finish line. Let's synthesize everything. Let's create a mental pocket framework for the listeners. If they are walking into a room right now with a brand new PE consult, What is the checklist they run through?
I break it down into the 3-lens framework.
Lens 1, diagnosis.
Check their pretest probability. Do not just autopilot to the CT scanner. Use an age-adjusted D-dimer age times 10 or the years algorithm to confidently rule it out if possible.
And if you do need to scan,
CT pulmonary angiogram is absolute king. And remember, an echo is for risk stratification, not diagnosis.
perfect. Lens 2, risk stratification.
Use the new alphabet. A, B, C, D, E.
Run through them one last time.
Category A is your incidental asymptomatic patient. Category B is symptomatic but totally low risk, meaning an SPZE score of 0.
Category C is the watcher.
Right, symptomatic with a high score or active RV strain. Category D is incipient failure. They are the teetering patient with normotensive shock. And Category E is full cardiopulmonary failure, the crash.
And finally, lens 3, treatment.
For A and B, discharge them from the ED if they meet Hestia criteria. Start the DOAC and send them home.
Category C.
Admit them. Anticoagulate them, preferably with LMWH. Monitor them closely and consult your Peter. Admit directly to the ICU. Call PERT immediately. And actively consider your advanced therapies like catheters or lysis.
Category E.
ICU PERT. And advanced therapies are fully reasonable. Push the TPA or get them on ECMO.
That is clean. That is incredibly actionable. And please, for the love of all that is holy, do not put in an IVC filter just because you are nervous about the clot burden.
And if the CT scanner is down for maintenance, do not practice radiology by vibes. Use your clinical probability tools.
Stay vigilant out there. Check your patients meticulously for those subtle Category D signs. That clammy, sweaty, normotensive shock state is arguably the most dangerous phase because it looks deceptively stable on the monitor.
Utilize your PERT. The team is there for a reason. Don't be a solo hero.
Well, this has been an incredibly thorough deep dive into the Circulation Guideline 2026. As always, this discussion is for educational use only. Follow your local hospital protocols, don't sue us, and let's go check on that admission in Bed 14.
Sounds good. See you at the next rounds.
Oh, actually, one final provocative thought to leave you with before we sign off. The guideline heavily emphasizes asking about symptoms for a full year to catch CPD. But ask yourself, honestly, how many of your PE patients actually have a dedicated follow-up scheduled with a clinician who even knows to ask about it?
Yeah.
If your answer is, I don't know, that is the very first thing you need to fix in your hospital system today.
Wow. That's a total mic drop.
See you next time.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve, pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.